Hello everyone, for this edition of Common Encounters in Cardiac Care, we will be going through when to suspect familial hypercholesterolemia. Familial hypercholesterolemia, or FH for short, is one of the most commonly inherited lipid disorders and is thought to affect 1 in 200 to 250 people worldwide. It is estimated that around 20,000 people in Singapore is afflicted with this condition. Early diagnosis is important as these patients are at 20 times higher risk of getting heart attacks, and hence early intervention is crucial. The Dutch Lipid Network is one of the most commonly used diagnostic criteria for FH. It utilizes 5 parameters to diagnose FH. The parameters are family history, clinical history, physical examination findings, LDL levels before treatment, as well as DNA analysis to assess for functional mutations. A score of more than 8 points is required to make a definitive diagnosis of FH. Tendon centromas and arcus cornealis are physical manifestations which are strongly suggestive of FH. Tendon centromas refers to the thickening of tendons due to cholesterol deposits in the connective tissues. The Achilles tendon and finger extensor tendons are the most common sites of involvement. Arcus cornealis manifests as a grey arc around the outer ridges of the cornea and is reflective of cholesterol deposits around the corneal rim. This sign is more specific in patients less than 45 years of age. There are 3 main genetic mutations which causes FH. These genetic mutations can affect either the LDL receptors or the ApoB or PCSK9 proteins. Ultimately, these gene mutations impair the uptake of LDL into the liver from the bloodstream and hence leading to a very high LDL level. So what are the targets of these patients in terms of their LDL levels? The ESC recommends patients with FH with no major risk factors to have an LDL target of 1.8 millimoles per liter, and patients with established coronary or vascular disease or other major risk factors such as hypertension or diabetes to attain an LDL target of 1.4 millimoles per liter. In terms of treatment options, patients with FH who does not have yet an ideal LDL level should be initiated on the high-intensity statin with subsequent sequential additions of ezetimibe and PCSK9 inhibitors to achieve the ideal LDL target. Fourth-line therapies are typically reserved for patients with homozygous FH. Patients with FH or suspected FH should be counseled for genetic testing. If a causative genetic mutation is found, cascade screening is recommended, whereby first-degree relatives are also encouraged to also undergo genetic testing. The Ministry of Health has also launched a national FH genetic testing program in late June this year. Under this program, patients with LDL levels of more than or equal to 5.5 millimoles per liter are eligible to receive subsidized genetic testing for FH, and if a causative mutation is found, subsidized cascade testing can also be offered to first-degree relatives. Thank you very much.